afternoon, everybody. I'm Lesley Stafford from the Hospital in Melbourne, and I'm delighted today to be your MC or chair for the online edition of VCCC Cancer and COVID-19 in Victoria webinar, in which we're partnering with MPCCC. So I'd like to commence with an acknowledgement of country. I'd like to acknowledge the traditional custodians of the land on which today's presenters are located. I would also like to pay respects to elders both past and present of the Kulin Nation and extend that respect to other Indigenous Australians present online. So welcome to today's presentation, which is entitled Exploring the Emotional Landscape of Healthcare Workers. But before I say much more about the content of the webinar, I'd like to take this opportunity to talk to you about the Victorian COVID-19 Cancer Network, or the VCCN, which is a response to the challenges involved in managing cancer care amidst the current global health crisis. So the VCCN is a joint initiative of the VCCC, the Victorian Comprehensive Cancer Centre, and the MPCCC, Monash Partners Comprehensive Cancer Consortium. And it aims to provide support and advice to clinicians and healthcare services treating patients with cancer during the pandemic. The COVID-19 Cancer Network collaborates on a digital platform for professional discussion, information and support as the pandemic progresses. So if you're not already a member, I would encourage you to log on, have a look and join, please. Just some information about upcoming events. The VCCC have some very interesting speakers coming up next week, so please register your interest at the VCCC website. They also have an open learning page if you would like to view previous topics, including previous COVID-19 and cancer specials. Just in terms of housekeeping about asking questions, if you have any questions for today's presenters, you can ask these questions via the GoToWebinar platform. Please do ask your questions throughout the presentations, and we will aim to answer as many of those as possible at the end of the session. All right, to today's presentations. As I said, the title of today's talk is Exploring the Emotional Landscape of Healthcare Workers, is the theme of the webinar. And look, I would think that COVID-19 needs no introduction, but whether one is a healthcare worker or not, the mental health and emotional impact of managing this lethal but invisible enemy has felt increasingly relevant in recent days here in Melbourne. I think that healthcare workers feel the same level as uncertainty as others in the community. Our uncertainty is certainly compounded by our limited knowledge and experience with the disease, and then also with the steps taken to manage its spread. So for many, the road from feeling uncertain to full-blown panic can be quite short. And as I said, certainly in the last few days, what previously felt like a very abstract threat, certainly when we were planning this webinar, now feels that much more real. So I'm joined today by a number of experts, including psychiatrist Dr. Toby Winton-Brown and Dr. Kim Jenkins, each of whom will give a presentation, and then we'll have a panel discussion after that. And we are joined on the panel discussion by Dr. Maria Fitanu, clinical psychologist, head of psychology at Peter Mac Centre. So it gives me great pleasure to introduce you to our first speaker, Dr. Winton-Brown. Toby is a psychiatrist, consultation liaison and neuropsychiatry at the Alfred Hospital. He trained in Sydney, London and Melbourne, and he now works in critical care, respiratory and neurology environments where he has developed an interest in understanding healthcare worker experiences. He recently co-founded an in-house initiative providing free anonymous counselling to healthcare workers experiencing distress and burnout in the workplace. Toby will provide an overview of data from surveys conducted with frontline healthcare workers during the peak of COVID, and this will be in an attempt to make sense of what has been seen and what is yet to come. So welcome, Toby.
Thanks, Leslie. I'll just try and share my screen now. So thanks again for inviting me to be part of this webinar. It's obviously very timely, particularly given the events of the last couple of days and even this morning in Victoria. I guess I wanted to start with some early data from just our experiences down at the Alfred, which has been one of several hospitals going through a lot of change, and just highlighting that one of the new front lines that's been discussed increasingly is the mental health impact of COVID. And this is very much something that a lot of these words are being talked about, being an unprecedented demand and overwhelmed services and all these kinds of things, leading to lots of changes in our working environments, dilemmas about balancing your own physical and mental health care with your patients, and aligning your duties to work and those to your family and friends. And that's without having to go through the dilemmas of our colleagues overseas with allocating resources and some of the much more complex decisions to make around there. And we're aware of this idea of stress building in us, increasing our performance up to a point, and where stress is either more severe or prolonged, and we've had both of those, we start to see ourselves going down the other side of the hump of this curve, and we start to become exhausted, ill, and more distressed. And I've stolen this slide from Kim, who's hopefully going to follow up this talk with just a curve of what might happen in the emotional responses to the anticipation, experience of, and then following a kind of crisis or a disaster. And this is a very time-limited one, but just pointing out that there's a real trajectory that is followed from us going through a sort of heroic pulling together in a honeymoon period, followed by some real disillusionment and some post-traumatic sort of experiences as we look to reconstruct. And so normal responses that I think many of us could probably relate to is just a real sense of increased anxiety in ourselves about our own health, uncertainty in others' health, feeling helpless, unsure what to do about it, and the sort of chronic effects of that, and then that impacting on our confidence about our normal roles, the systems around us, and how we function in those, as well as some sense of loss about what's changing and what we had planned, and many of our connections with others, and then some more complex emotions like guilt, particularly guilt in healthcare workers, I think, who are used to working in a particular environment of control and competency. Guilt about feeling uncertain, feeling afraid, and guilt about not being able to do as much, guilt about not wanting to do as much, or not feeling as much as one should. And I think some of these more complex and under-articulated emotions can really contribute to an impact on us as we move through something like this. And increasingly, some good commentators are drawing links between this experience and that of war. And Neil Greenberg, who's a psychiatry professor of military psychiatry in the UK, along with Simon Wesley, have made these links between military examples of what they've called moral injury and healthcare examples. And so putting yourself in the new kinds of moral dilemmas where what you have to do or what you're unable to do might be conflicted with your professional or your personal codes of values and ethics. And all this does have an impact, and we know early on that there was some large mental health impacts on healthcare workers in Wuhan, and this paper published in, I think, April in JAMA Open pointed this out, and they did a pretty heroic rapid cross-sectional survey of over 1,200 healthcare workers in 34 hospitals in Hubei province. And they were, this proportion of people, sort of mostly female, 1/3 medical, almost a half frontline workers. And they found some pretty compelling findings that according to these instruments that they used, which are standardized instruments for depression, anxiety, and PTSD, that up to half were experiencing major depressive episode, nearly a half of generalized anxiety, and 70% experiencing significant symptoms of PTSD, which is quite impressive. And they found that those were worse in those in the front line, those in the middle of Wuhan, in nurses and in women, and in secondary rather than tertiary hospitals. And they speculated that was because the tertiary hospitals might have been more equipped and prepared. They didn't have any baseline data to compare pre-COVID, so we don't really know the additional impact of this pandemic relative to what their workers were going through normally. And they didn't really look at some of the driving factors. Nevertheless, it was a pretty big headline finding. But then when you go back and look at the criteria they used, this was for all symptoms. So anything other than a normal score on these scales was included. And if you go back and then limit it to those in the moderate severity range, so people experiencing moderate, medium levels of depression and anxiety symptoms, they're sort of much more modest, but still pretty significant, particularly that PTSD figure. So saying that a third of people are experiencing at least moderate level symptoms of PTSD. So reading this and in anticipation of what was happening in Melbourne and at the Alfred, some colleagues from ICU and myself decided to just replicate that. So we used the same instruments using the same strategy. Now, we weren't quite as heroic. Ours was 320 healthcare workers, and we were just in the one hospital, but that's a reasonable number of our clinical staff. We had a similar proportion to the Wuhan study of female to male, similar amount of doctors to nurses. We additionally recruited allied health staff, which are a big part of our workforce here. We had some non-clinical and other staff, and similar to the Wuhan study, around 40% of ours were frontline versus not frontline, and that we defined as people who are working in direct contact with people with COVID. So using the same criteria and the same instruments, we found half had depression, half had anxiety, and 80% actually met the same level of PTSD symptoms using the same instrument. Again, if we just limit that down to the more moderate to severe range, we get similar numbers. 20% of our staff surveyed had moderate to severe symptoms of depression and anxiety, and just under 30% with PTSD. Now, if we compare that to the Wuhan figures in red, they're quite similar. Now, we have to be cautious about this because our data are sort of preliminary and we didn't survey as many people, so we're prone to probably some bias there. But just looking at that is quite a significant amount of mental health impact cross-sectionally captured. In contrast to Wuhan, we didn't find it worse in nurses. There was no gender difference when we adjusted for other factors, and frontline working, so direct contact with COVID, didn't make a difference in our numbers. The only profession that did better, reportedly, was senior medical staff, and that's consistent with some previous data from what we know about more experienced clinicians from a Beyond Blue doctor survey. Similar to Wuhan, we didn't really have much baseline data. We've got a bit, but they're using different instruments and in probably a different cohort of staff. And we did look at some of the driving factors, and we found, using, again, valid instruments, that burnout, which was over threshold for about a third of our staff, and conversely resilience, as measured using a standardized instrument, were the best predictors of anxiety, depression, and PTSD. And when we asked people about their own psychiatric history, that was one of the big drivers of an experience of depression in the COVID pandemic as well. So these are some of the drivers. We also did a qualitative exploration. I think this can be really informative, and what I'd like to do is just take you through some typical responses and how that might inform our understanding of the experience of healthcare workers in the last couple of months. So what we did is, in a subset of those survey respondents, so this was 274 people, we asked these 5 questions. What have you found to be the greatest challenge whilst working during the pandemic? What's been the greatest challenge outside of work? What are your biggest concerns for the impact of COVID-19, and what would help the most? And then lastly, what do you find are the most useful strategies for self-care? And we subjected this to a reasonably rigorous inductive content analysis with some qualitative statisticians or researchers that I work with, and they developed 7 main themes to do with patient care, the changed working conditions in the hospital, how it is working in the hospital environment, the impact of the pandemic, the impact of isolation and uncertainty, how leadership and management affects the impact, and what sort of support for staff and self-care. I'm just going to talk you through some of those. So for patient care, most respondents were really concerned about how to provide appropriate patient care for all patients, and particularly end-of-life care. I'm just going to let some of these quotes come up so you can read them as I'm talking. But this experience of having to restrict visitors, I found really difficult repeatedly for not just patients with COVID, but for other patients. And that was very, very distressing for the staff as well as the patients and visitors. Changing working conditions, and this was a day-by-day change, and it still is, and particularly issues to do with redeployment and retraining, the restrictions of working from home and how to balance the obligations for children and homeschooling, and then the idea about how career planning and training is going to be impacted on. Working in the hospital environment, people were worried, of course, about directly catching and spreading the virus and bringing it home, how they can mitigate that personal risk, concerns about accessing and using PPE, wearing it all day, and how to deal with the process and infrastructure aspects of that. In bigger picture impact of the pandemic, people were worried both about their own mortality and the impact on the community, particularly vulnerable people, and the effect on the economy and on their own and others' financial security and job security. The impact of isolation and uncertainty, really to do with family and friends, and the fact that as well as having all these uncertain changes and the impact at work, a lot of the strategies and connections we use to manage our own stresses changed or unavailable. This is some very poignant statements coming up from some of our survey respondents here. Some of our respondents thought that change management and communication were key, and this was obviously hard for the leaders as well when things were changing day to day. But where there was a clear and consistent and limited communications, that was most helpful. But obviously there is uncertainty inherent in this, and so and dealing with that is just difficult. And we had a lot of people having to go through a phase of deliberately turning off their devices and cutting off their connection from the news, because as they got more and more into the pandemic, they noticed themselves getting more and more distressed as they listened to more news. And the last one is about how people want and best are supported for themselves and from their workplace. Empowering staff, listening to them and implementing the changes. There were some comments from non-clinical or other staff that mostly frontline workers were getting all the support and the attention, but that many other people are impacted as well, and that they've been forgotten. And then people saying that they use mindfulness, time away, outdoor activities, connecting with others, and just lowering standards, reaching out when you can. And so those were really, really rich and useful, I think, and reflected this other paper that, if you haven't seen, I'll draw your attention to, which is from JAMA a couple of months ago. And people saying not that they just need mental health support particularly, but they need real listening and preparation and care. And they summarize it in this great table that says, hear me, protect me, prepare me, support me, and care for me. And they talk about what the main desires and concerns and responses were in those domains. And so at the Alfred, we've tried to think about this, and this is really sort of a hierarchy of getting the basics right: information, care, equipment, knowledge, training, emphasizing care for self and caring for others, and then reaching out if you need to. And that's reflected in this intervention pyramid from psychological first aid. That what most people need is basic services and knowledge and communication, and strengthening the normal way of supporting each other within a community, whether that's at work or at home, and then focused more specialized supports for those people that need it, such as psychosocial first aid and then clinical services. And at the Alfred, during this time, and I know that a lot of other hospitals are developing similar things. We've tried to enhance some of the mental health and wellbeing measures for the staff, and we've developed a new wellbeing collaborative that's got a whole range of people involved in it, and focusing on consistency of communications, basic food, equipment, PPE, scrubs changing areas. We've done targeted wellbeing and mental health workshops repeatedly with different staff groups in ICU, ED, respiratory, other areas. We've developed psychological first aid training. We've brought the EAP, the Employee Assistance Program, on site, and we developed a new in-house confidential tele-support service staffed by senior clinical psychologists and psychiatrists for the Alfred. And we're doing the ongoing survey, and in the survey, people are given feedback on their scores. They can track them, how they're going, and there's links to connect with us at Alfred Minds as well. So that's my bit finished. Thanks to the people involved in the study, and very happy to take questions or participate in the panel later on.
Thanks very much, Toby. That was, I think, setting the scene quite beautifully with the local data. Now, our next presenter, Kim Jenkins, is actually having some difficulty logging on. So in the interim, I might ask Toby a question, and if there are any other questions for Toby as well, please do send them through in the interim. Struck by the very high rates of PTSD in the Alfred sub, and I sort of wondered a couple of things. One is, were you surprised by those rates? And another is, given issues of confidentiality and stigma around mental health, even amongst enlightened health care workers, did you get a sense of what sort of support these healthcare workers were already accessing in the community at the time, or were they reliant on or waiting for the hospital to provide some sort of support to them?
Yeah, so thanks, Lesley. It's good questions. I was surprised. I was surprised just by the prevalence of everything, really, even when we limited it to quite, high levels of cutoff. And I guess I didn't have a real sense of what was out there already. And I mean, the limited baseline data we had was from HR delivered surveys, which aren't using the same kind of validated instruments, but do say that around 20% of people, when you ask them, are experiencing moderate to high levels of stress in the workplace. And we don't really know where that comes from in those people, but that's been a consistent finding in those surveys, and not just at the Alfred, in the People Matter surveys that go out from the sort of more government level surveys show a similar level of stress and distress. But the degree of PTSD and the replaying things over and over, I think, was quite shocking, I thought. And we know a little bit from the people. So people in the survey had the option of, it was an anonymous and confidential survey, and I think that was very important because specifically of your point about stigma and what we know that is, it's hard for healthcare workers, it's hard for doctors and nurses to own up to acknowledge that they are experiencing stress and distress, and that they're struggling at work, and so for those people, it had to stay confidential and anonymous. And despite that, I think we still had some reluctance to participate. And for the people who left their contact details, so people had the option of leaving a phone number or an email, and I spoke to many of them. They were sharing those difficulties for the first time. Some of them had psychologists, some of them had experiences before, but many of them were doing it for the first time, and they were surprised themselves about just how high their scores were and just how highly impacted they were, when they did those questionnaires for the first time. So that's why we did create this new service, because we found that for many people, and this was true in the workshops we ran as well, that they thought that although the employee assistance programs are there and are good and experienced, that there is a stigma, or at least an anticipation of a stigma or a self-stigma associated with actually formally reaching out for that. So I think this is a real barrier, and this is something that's known. You know, healthcare workers experience a lot of stress and distress, and they find it hard to acknowledge it and hard to reach out. We also know that a lot of the way that everyone deals with stress, particularly emergency workers and healthcare workers, is through each other, through debriefing and winding down and talking about it and just making it okay. And I think that's the basic principle of a healthy workplace, and of more, you know, of psychological first aid, just to facilitate that normal process of sharing and correcting and making okay. And that's actually been disrupted as well. So that's something that we've been trying to figure out, how we can keep that flow happening and keep that process happening, despite people not being able to go have a coffee or go to the pub or do whatever it is that they need to do, and not being able to connect with their families and friends. So yeah, I think there's a lot of need there. Yeah.
Okay, Toby, we have a question from Joy Forster, who's the CL psychiatry nurse at Peter MacCallum Cancer Centre. And her question is, how does debriefing fit into staff support if the exposure to the source of distress is enduring and ongoing? And I wondered if you had any thoughts on that.
Sorry, I just missed the first part of the question, Lesley.
Perfect.
The first part of the question was, how does debriefing into staff support if exposure to the distress is enduring or ongoing?
Yeah, that's a hard one. So, and debriefing, you know, formal debriefing, I think, is something that we've sort of evolved our understanding of, because of the work that showed that you know, compulsory mandated debriefing doesn't necessarily help and may worsen things, but it is done, I know, in ICU, our ICU, after they've had particularly traumatic cases that have been very complex, where the traumas are ongoing. I think the process is more about how you build in a regular debriefing at the end of or at the beginning of shifts, and I know that in some workplaces they do huddles, they do end of shift sort of debriefs or chats, and that's something that was being done very successfully, including some mindfulness exercises at our emergency department for a while, and then for various reasons to do with COVID, that's had to change. So we're again trying to figure out how we can reinvent that or reconfigure it. The other thing that's powerful, I think, is when leaders and mentors model vulnerability and model doubt. So in some of the sessions that we had in the ICU, for example, with the ICU registrars, the junior doctors, some of the ICU consultants were a part of that and talked quite frankly about experiences that had during their training and experiences that they still have where they doubt what happened, or they feel like they've done things, they could have done things better, or that they experience some difficult emotions around it, and that's an okay thing to do. So I think this modeling and creating an atmosphere of dialogue and reflection within the team, not overly formal, not overly facilitated, not by a mental health expert, but something that just becomes a part of the culture, modeled and continued and validated by leadership, can be very valuable. And after those sessions, the registrars, the ICU registrars, really noticed that and really found that quite powerful. So I think that's one of the ways in which you have to, I think, make these processes built in to the work that you do.
Thank you, Toby. And I have a follow-up question to that, but we'll come back to that because I believe Dr. Kim Jenkins, is with us on audio, although I'm not sure that we visual. So as I said, Toby had set the scene quite beautifully with the local data and some of the sentiments in that, particularly in that qualitative data, would be familiar to many of us as health workers and indeed to people in the community. So I think Kim Jenkins now will present on how healthcare workers can be supported at home and at work with all these additional pressures that we're facing. And Kim will demonstrate how colleagues can start difficult conversations and move forward during these challenging times by applying compassionate, collaborative leadership to help transform our healthcare systems. I'll just tell you a little bit about Kim Jenkins. She's chair of the Council of Presidents of Medical Colleges, immediate past president of the Royal Australian New Zealand College of Psychiatrists, and chair of the Migrant and Refugee Health Partnership and board director at Mental Health Australia. Kim is also an adjunct senior lecturer at Monash University and an honorary senior fellow at Melbourne University. She's previously held leadership roles in medical education, medical workforce, and medical practitioner wellbeing. So it gives me great pleasure to welcome Dr. Kim Jenkins to talk about psychological responses for care workers.
Hello, it's Kim here, and I'm sorry about the fiasco here at this end with my slides and not being able to join you with any visuals in the webinar. But I think you've got my slides up on the screen now. Thank you for the introductions, and I've heard a little bit of the webinar so far, and I apologise if in any way I'm repeating things that have already been said, but that's probably because they're worth repeating. At the beginning of COVID, some colleagues and I got together and thought, as mental health practitioners, how can we contribute to, you know, what can we actually do to help with COVID? And we thought putting our heads together and coming up ways of helping us support our colleagues and helping the understanding of what we might all go through with emotional responses and psychological responses during the COVID was probably one of the best things that we could be doing. So the first document that I've put up here was the first document that our writing group produced, which was Minding Healthcare Workers. And Margie Stutchbury was the key author on this. And what we've got up there is a graph of what we've called the emotional landscape of healthcare workers during COVID. And this is a graph that's come from other trauma research and disaster research about the emotional highs and lows that we experience in response to a disaster or adversity. And how, if you look at the left-hand side, we've got your emotional levels, which we're sort of presuming before the disaster strikes are at a sort of medium sort of level, and how in the pre-disaster area you're sort of like getting to feel a little bit low, and then you get to a low when it impacts. But very rapidly we move from an impact phase into a heroic phase, and then we have a honeymoon and we feel good for a while, and then we come into disillusionment before we move on to reconstruction. We had a look at this graph and thought it's probably going to be very different in a pandemic, because this work was done as a model for a sort of more discrete disaster, or like a bushfire or a tsunami, that given that we knew COVID was coming, there was going to be a prolonged build-up and preparation phase, and then there was likely to be a very protracted delay in entering the reconstruction and recovery phase. So we knew that what we've already got in the way of modelling for psychological responses in disasters wasn't quite going to fit COVID. And just sort of things like in the impact phase, it's fear and uncertainty that can be quite dominant, and you worry about protecting yourself and your family. And then in the heroic phase, you get this surge of energy and take on more than you usually would, and you feel sort of like want to do something useful and feel needed and relevant. And then in the disillusionment phase, which I think is where most of us are sitting now, with further dose of disillusionment with the extra lockdowns in Melbourne at the moment. There's a definite shift in emotions, and you can feel overwhelmed and exhausted. And you reach the limits of the resources and assistance sort of available to you. And this is where there's a sort of potential for moral distress and burnout, and where we need to really connect with others. If we have a look at the next slide, which should have two charts on it, it should have an inverted triangle and some comments about connection there. If you look at the right-hand side of this, this is sort of like the pyramid of Maslow's hierarchy upside down, stood on its head. And through the impact phase of a disaster and the heroic phases, probably our priorities for all of us as healthcare workers were like PPE and, somebody has lost my slides maybe, or lost my slides. So I'll try and talk to this without slides. But in the impact and heroic phases, we worried about safety, like PPE, and have we got adequate training, and do we trust our senior management, and our physiological needs like sleep and nutrition and breaks and things. And then as we journey through the heroic phase into the sort of disillusionment and recovery, we're much more concerned about our emotional well-being and connectedness. And we're really trying to make work feel meaningful. And it does feel meaningful in the heroic phase, but we can lose sight of that in the disillusionment phase. And as I don't have much time left, I'll whiz through onto the next slide, which is actually a picture of of ammeters, which we put at the end of our first document about minding healthcare workers, just so people could actually have a check. We can all check to see how we're traveling at the moment. Like, are we feeling as compassionate as usual? Or are we as emotionally connected as usual? And we just suggested that it's worth sort of checking in with these slides to see how we're traveling from time to time during the course of the pandemic. I'm not going to have time to actually say much about how we feel in each of those phases of the pandemic. But I will go on, and the paper's available to anyone who wants to get it. But I'll just talk about some of the other work that our group's been doing, which is about how we support each other at this during this pandemic. And one of the resources that has actually grown quite dramatically during the pandemic is peer support. And the beauty of peer support is it's not a clinical intervention. It's us looking after ourselves and helping our colleagues out. And peer support's actually grown in prominence a lot lately. If we just go on to the next slide, which has got a picture, you should be looking at a slide with a picture of two people sheltering under an umbrella. There's lots of different definitions of peer support. And it can be very formal or structured in groups, or it can be one-to-one, and it can be in the workplace. But the important thing with peer support is we're with somebody else who is experiencing the same trauma or been through the same sort of trauma. And you get peer support groups sort of quite spontaneously developing in things like men's sheds or parent-infant groups. If we can go to the next slide, please. And it's a way of receiving and giving support based on respect and mutual agreement. So there's no actual formula for this is proper a proper way to conduct peer support. It's what suits for the dyad or the group. But what is important is that there's commitment to the peer support and an acceptance of shared responsibility, and that it can be confidential. If we go to the next slide, the other important thing about peer support is it has to be between peers, and it doesn't work if you've got a peer support group where somebody is employed by somebody else or somebody is in their direct line of authority or reports to them, especially if it's work-based peer support, because openness and trust are absolutely essential, but it should provide a safe place for workers to connect with each other and with others with similar experiences. I'm not saying that like supervisory relationships or mentorships are not supportive. It's just not peer support. If we go on to the next slide, which says nature of peer support, it's about listening and understanding and empathizing and us sharing the experience and taking a journey together. It is not therapy. And it's about helping each other to find our own ways of coping that have helped in the past. Sometimes it's about suggesting new ways of coping, but it's not for us in a peer support group or peer support setting to take over somebody else's problems or get into problem solving mode and actually do the work for them. It's literally about taking a journey together, as I've said. If we go on to the next slide, which comes from the third document that the writing group have produced, which is probably going to be the most relevant one today, which was about difficult experiences when working in tough times. And this is about identifying burnout and compassion fatigue and traumatic responses. And if we go on to the next slide now, there's been a lot of talk about burnout on social media and a lot of awareness that in the time of COVID, people may be becoming burnt out. And it is a concern because you lose good staff and people may leave the organisation or the sector due to burnout. And it has emotional health consequences to the employees themselves and to family and friends. And burnout is really about becoming upset and negative in the workplace. And you can feel angry and guilty and sad and worry. But as I've put on this slide, on the way to burnout is what's known as presenteeism, when you're still there, but you're there in person, but you're not emotionally there, or you're not there in body. And so if we go to the next slide, I've put up the signs and symptoms of burnout. And I particularly like the second one, which was daydreaming of other careers, which a few years back, I didn't want to be a doctor. I was really burnt out as a general practitioner and everything was going to be better than work. My fantasies of other careers was going into home decoration and designing cushions. So we can all feel burnt out from time to time. But the risks of burnout are that we distance ourselves from our loved ones. We're not so productive. We put things off. And our usual sort of, nice, lovely persona that we have at work is lost, and we can become more irritable and sort of detached and hopeless about things. And then our patients bear the brunt of that as well, because we've got decreased compassion, and the patients can feel less cared for. The warning with burnout, though, is that a lot of the symptoms of burnout can overlap with depressive symptoms, and it's not that big a step to go from burnout to depression. So it's always sort of, if you're a clinician and a mental health clinician, it's always worth thinking, is this really burnout or is this actual clinical depression? And it's much easier for people to come and see you and say, I'm feeling burnt out because of work. It's far less stigmatizing for them than saying I'm depressed. But if we go on to the next slide, and I'll rush through this because I haven't got much time. This is a slide about compassion and compassion fatigue. And compassion fatigue is when we find it hard to be compassionate and we feel like there's nothing left of ourselves to give, and we feel like being empathic and tuning into the emotions of others, something that many of us pride ourselves on doing. We just can't do it. It's like your cup is full to overflowing. You haven't got any space for anybody else's emotions. And it can come with a sort of sense of loss of control and morale, and you can feel sort of physically and emotionally exhausted. If we go on to the next slide, which is about trauma, and I'll go very, very quickly through this, and onto the slide after that, which is trauma in the workplace. And we talk a lot about being traumatized at work. I think the important thing to actually remember here is most people after a traumatic event go back to their usual level of functioning, and it's only a few who have enduring impact and negative effects. And the following slide shows, and I'll make these slides available, what the effects of the trauma, what they depend on. But there, the workplace culture and response and the available support networks is incredibly important. And I think I'm getting a message that I'm running out of time.
Yes, I'm sorry to interrupt you. It's very, very interesting and so relevant, but I just would like an opportunity to ask some questions of the panel as well. And it gives me great pleasure to formally introduce Maria Furtado, who is the head of clinical psychology at Peter Mac, also a research fellow in the School of Population and Global Health at Melbourne University. Maria has over a decade and a half of clinical experience in psychosocial oncology, and she and her team provide evidence-based psychological interventions to people with cancer and their families across the cancer trajectory. And I guess my question really is, at this stage, is for Maria. I think it's reasonable that many people look to Peter MacCallum as the sort of gold standard in cancer care. And while I realise that Peter Mac itself has not had to deal with a lot of COVID cases, cancer clinicians and institutions in smaller areas would be asking, what is the best way to manage the mental health of our staff and to support their well-being? And what are some of the lessons that you have learned at Peter Mac, and what are some of the opportunities that you see going forward?
Thank you, Lesley, for inviting me to be part of the panel. And we've learnt a lot during the last few months, and we've all been very, very busy. And a lot of the stuff is really the stuff that Kim and Toby have been talking about. So the first thing that really has been really important is good communication, and that's throughout the whole organisation. Really being briefed about how we're going to work, what's happening, what changes are happening, how are we managing the flow of patients in and out of the hospital, are we going to be wearing PPE or not? All that stuff has been from the CEO down to managers, down to everybody, the communication has been crucial. And I think the other thing that I'm particularly proud of that we're doing really well at Peter Mac at the moment is a non-blaming, really supportive work culture, and that we're in it together. And there's been a huge promotion of mental health and the importance of mental health. So like the Alfred and what Kim has been talking about, we've really invested in our peer support networks and we call it at Peter Mac our care champions, and have done a lot of psychological first aid with our peer peer support workers and who have been interested in supporting staff further. We've also did a little bit of what the Alfred spoke about, but ours is a little bit different, is having a psychological support line for staff. But our support line is that we don't provide the psychological counselling. We're primarily, if a staff member calls in, we help them get the help they need in the community and help make referrals, because navigating that path is really, really difficult. But other things that have been really important to my team have been, and the rest of us, flexibility. Like people, when schools close, being able to manage your children and do some of the work from home has been really, really important to keep the psychology department going. Really important to, we're all very busy and stressed and sometimes have forgotten our colleagues, but really valuing and providing feedback to our colleagues on the work that they've been doing, some of the things, but we're all learning as we go through it. And as I think the panel said, there's no real plan of how to make this work. So we're learning through our colleagues and across the world, really.
Thank you. Thank you. I also had a question for Kim, please.
Okay, okay.
They're great. I wondered if you had any particular advice. I'm asked about this fairly often for healthcare workers going into the hospital, whether they're in a hotspot or not, whether there are lots of cases or not, what they tell their children and their families about being safe and how you manage some of that tension.
Oh, that is really, really hard, because it'll sort of depend very much on the individual worker and their families and their mode of communication with their families. But I think, and it'll depend on the age of the children and things, but in whatever way you feel is best received by your children, to be sort of fairly open and honest, but miss out the frank and the gory details, and reassurance of mum or dad or whatever your relationship with the kids is taking all the precautions at work, but it's a nasty illness, and explaining it's one we can't see and all the rest of it. But I think also some frank explanations to children about, when I come home from work, I'm likely to be a bit more stressed than usual, and I might just need a few minutes to myself to unwind, or have a few moments to get work out of my head before I concentrate on the kids or do things with the children. And I know that sounds terribly idealistic, to think that you might have a couple of moments to yourself before looking after the kids and trying to juggle what's been homeschooling as well. But keeping it fairly open and honest, but making sure that the message is delivered in a way that the kids can understand. And there are some quite good resources there for how to talk about COVID to your children in cartoon books and things. And I can send through, if people are interested, I can send through some details of some that have been recommended to me in that area.
That would be very helpful. Thank you.
Yeah. And I think that most children like to know what's going on for their parents and why things might feel a bit different at home, and offering them an explanation is really helpful. Better than the keeping secrets or sort of, nothing's wrong, we'll just get on with it. It's to actually say, yeah, work is a bit, mum's work is a bit tough at the moment, or dad's work is a bit more tough at the moment, and there's a lot of sick people. Or people are sick in different ways.
Toby, a question for you, and I don't know if you've analysed the data at this level of detail, but was there a difference in the survey data in terms of exposure? So were there different rates of psychological morbidity in full-time staff compared to part-time staff? Toby, you're muted.
that better? Yes, so the frontline staff were defined as those who did have direct exposure. So as in they were working with COVID positive patients. So, and looking at those, by that definition, there was no difference at all in those measures of depression, anxiety, and PTSD. Similarly, we defined it in terms of working in what we call a high exposure environment. So staff working in ED, ICU, respiratory, or infectious diseases compared to other areas. And we found a small signal for those areas being slightly high risk for PTSD and burnout, but not otherwise. And the third definition, which is whether people actually were furloughed or had a contact with someone otherwise, we actually weren't able to check that. But we did have large numbers of staff sort of furloughed, as everyone did, you know, on and off, and we weren't able to correlate that, often because the furloughing period was quite brief. So, and there was another question in the chat about part-time as well, and we weren't able to compare. But yeah.
We are just about out of time. We do have a slide that has been prepared for us with some information about where health professionals working in oncology can find reliable, good information, and those are up now. Also, would invite panel members, if you do have other resources that are appropriate and useful to share with people who logged on today, to make yourselves known by contacting either myself or one of the other panelists, and we'll find a way to distribute those to people who are interested in. So that brings us, I guess, to the end of today's COVID and Cancer in Victoria webinar. And I want to thank everybody who has been involved today for their presentations, and also thank you to the audience for tuning in. There are some terrific themes and experts coming up in the COVID and Cancer series, and if you would like to join us, the next one will be on July the 10th, and the question asked in that webinar is, what should be different in the new normal post-pandemic? And that will be with Stephen Duckett from the Grattan Institute. So definitely something to tune in for. So thank you very much again, and I hope you enjoy the rest of your day.